Hello and welcome to the webinar, Patient-Centered Medical Home, a case study featuring the Mary Howard Health Center. My name is Melissa and I will be acting as moderator for today's webinar, which is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. A selected number of questions will be answered at the end of the presentation during the Q&A session. Thank you all again for joining us for today's webinar, and I now turn the mic over to our MC for today's webinar, Ms. Anna Gard. Anna?
Good afternoon, everyone, and thank you so much for taking time today to join us in one of our webinars as part of our series of webinars related to patient-centered medical home, featuring healthcare for the homeless grantees and their process and progress towards patient-centered medical home recognition. Today we are featuring Mary Howard Health Center in Philadelphia. Since 1985, the Healthcare for the Homeless program of Mary Howard Health Center has been bringing medical services directly to the homeless of Philadelphia in shelters, transitional housing day programs, and in street outreach. This model has proven successful in reaching and helping many of the homeless population in Philadelphia. The HCH program is administered by the Public Health Management Corporation and is under the leadership of Elaine. Mary Howard is the only primary health center in Philadelphia that solely serves homeless population and in particularly chronically homeless adults. This center provides comprehensive primary care services, including family planning, management of chronic diseases, behavioral health services, nutrition counseling, and assistance with applying for benefits and obtaining housing. In addition, Mary Howard is a nurse-managed health center that addresses the complex healthcare needs of the patients it serves. Elaine Fox, the lead administrator, serves as vice president of PHMC Specialized Health Services. And under her leadership, she has helped PHMC grow to include 5 comprehensive primary health centers, 2 for homeless people and 3 within public housing sites. She is the author of numerous publications, including Homelessness in Philadelphia, People's Needs and Services, Homeless Families in Philadelphia, and Children of Homelessness in Philadelphia, Health Status and Access to Health Care, as well as numerous papers and presentations related to the access to health care. She has developed the city's shelter standards and serves on many committees and task force in Philadelphia, and she was recently awarded the Philadelphia Public Health Executive of the Year Award by the Philadelphia Business Journal. Today's presentation will be given by Nancy Rothman, who is the Independence Foundation Professor of Urban Community Nursing in the Department of Nursing, College of Health Professions and Social Work at Temple University in Philadelphia, where she serves as the Director of Community-Based Practices. Her research focuses upon primary health care and community-defined health risks and prevention intervention strategies. She serves as the consultant to the Public Health Management Corporation Nursing Network, a network of nurse practitioner-led primary care practices. So without further ado, I am happy to hand the mic over to Nancy to begin her presentation.
Welcome, everybody. I want to give a little bit of an overview as we start, and one of our mantras is that patient-centered medical homes provide high patient and provider satisfaction. I'm going to start with some background, move in to what a medical home is, the Pennsylvania experience with the Chronic Care Initiative and our centers becoming medical homes, how to become a medical home in terms of the steps, the benefits of NCQA recognition, and the standards and the process. To set a context, Public Health Management Corporation is a public health institute, and the Healthcare for the Homeless program is one of the programs within PHMC, as we call it. And again, some of what Anna stated when she introduced Mary Howard, in addition to Mary Howard Health Center, which is the primary care center serving the chronically homeless in Philadelphia, There are numerous outreach services that are also under the Healthcare for the Homeless program. The 5 centers that they recognized Elaine for developing, it's kind of exciting because tomorrow we're opening the 5th center. So think of us, and that's Congreso Health Center, which is serving a primarily Latino population. Mary Howard on the left of this slide was the original program health center started by PHMC. And next came Rising Sun, then PHMC Health Connection, which are both in public housing, and then PHMC Care Clinic, which was the other one immediately before the Congreso Health Center, which is serving chronically homeless as well as treating people with HIV and AIDS. Mary Howard Health Center has been serving within this clinic setting since 1996. We currently have 4 to 5 full-time equivalency certified registered nurse practitioners. We do have a collaborating physician as required in Pennsylvania. We have a physician for every 4 NPs practicing at one time. Our population in 2010 at Mary Howard was 1,772. Diabetes is a major focus for our chronic care initiative. It's also one of the diagnoses that we have standardized protocols for our NCQA recognition is 188 at this site. And besides the nurse practitioners, we have a nutritionist, an optometrist that comes in weekly. We have 1.5 psych nurse practitioners, a psychologist, there's a behavioral health specialist, and a social worker on site. The concept of medical home was really introduced by the American Academy of Pediatricians in 1967, so it's not a new concept. At that point in time, it was a model of care for children with specialized health needs. Subsequently, it has evolved into an integrated primary care model. Nurse-led practices, I have to mention, were initially not recognized by the National Committee for Quality Assurance until October 22nd of 2010, when they did say that not in all states, but states that allow independent practice for nurse practitioners, that they would then begin to recognize that nurse practitioner-led practices. The characteristics of the medical home is that it is whole person focused. There's a long-term provider partnership, not sporadic and hurried visits. There's a provider-led team that coordinate care, especially for prevention and chronic conditions. Plus, they coordinate the care with other providers and with community support. There is also enhanced access to clinicians and the team and patient engagement. Recent recognition of medical homes has come about in both federal, state, and payer initiatives. They save money long-term through lower hospital and emergency room admissions. And so the Medicare demonstration projects, state initiatives, much as the Pennsylvania one that Mary Howard has been involved in, and then we're finding our Medicaid payer initiatives are all opting to pay some additional amount for those for the payer initiatives as those that have received NCQA recognition, and the state initiatives frequently require you to have NCQA recognition before you can remain beyond the first year of their projects. Pennsylvania's chronic care initiative is what moved us towards the NCQA recognition. It started in the southeast corner of Pennsylvania where we were, and there were 8 of these were nurse-led practices, of which 4 were with PHMC, 3 that were actual practices of PHMC, and 1 which is an affiliate. The components of that model are also consistent with requirements within the NCQA recognition. They included using the Wagner chronic care model for care, having a registry and reporting improved performance and practice goals, which began in Pennsylvania for diabetes. And they began with diabetes because it was where the state was spending the most for unnecessary hospitalizations. Continuation beyond the first year required that we had to receive NCQA recognition, or we would not be able to continue in their program. So that certainly was both a carrot and a stick for us. The Chronic Care Initiative included a number of learning collaboratives with coaching, which was very helpful for us. And it does provide a pay-for-performance program. And just to give you a feeling, at level 1 recognition, Mary Howard receives over $22,000 per quarter every 3 months. And this payment is coming from the payers within who, it's your payer mix. So it's not coming from the state, it's coming from the payers themselves. And when we move forward to hopefully reach level 3 in May of 2012, we will double that, and we would get $44,000 per quarter as a pay for performance. The Wagner model, I'm sure a lot of you are familiar with, and I'm just going to show it, and I'm going to move on and talk about these components, self-management, delivery system design, decision support, and clinical information systems, since they're a major part of what the NCQA standards address also. For self-management, effective self-management, we say, is very different from telling patients what to do. We're really having them decide what they like to do, and then we move forward from there, and hopefully if they find something they really want to meet and we support them in meeting that goal, they'll go on to select additional goals. My story for this usually is a gentleman whose wife died and was unwilling to set a self-management goal. And he was a patient with diabetes, and then at this point in time he finally came in and said, I know what I want to do. And what he wanted to do was he wanted to get a dog. And now I'm just saying that because it shows how broad you have to be willing to go. But the clinician realized that getting a dog would mean that he would walk and get more exercise, which eventually would affect his blood sugars. So, and then once he did that and saw some success, he was willing to select other self-management goals. The patients need to have a central role in determining their care, and we need to really foster their responsibility into their own care. And one of the things we did then, when they had a self-management goal, we developed a report card that we've been using in paper now, but with the new meaningful use requirement of a patient summary, we'll probably move to that as we move forward in the next few months. But I wanted to share with you what this did for the diabetic patients. It was colorful, and it not only addressed their goal, it shared with them what their current A1C was, what their blood pressure was, and what their LDL was. In addition, we wrote out their self-management goal, and then we went further in terms of motivational interviewing and asked them, how certain were they that they were going to get to that goal? And if a patient who said he was going to cut out, one of the things with our homeless patients is in the shelters they serve a lot of sugary drinks. If he was going to cut out all sugary drinks, and we'd say, how likely is it you're going to get there? He would say, maybe on a 5 on a scale of 10. We would try and cut it back to having him reduce it to maybe 2 for the first few weeks. For the delivery system design, it really clarified the roles of the team to ensure that we met the patient goals for care, and that the clinicians who took care of the patient had centralized, up-to-date information about the patient's status, and making follow-up a part of the standard procedure. And to do this, we ended up hiring RN care managers to work alongside our primary care nurse practitioner clinicians. We also involved training the MA in doing the ELEAP exams, which is a yearly requirement for diabetes, But when a clinician is hurried, they say, oh, I'll do it next time. I'll do it next time. And so we did training for the MAs with a competency test, which we continue to go back and check on. And when we started doing this, our number of people having their LEAP exam was way above the 90% level that we were, we were really striving for. We also began to give $5 gift certificates from local grocers. And for the Center City population homeless, I don't know if you know Philadelphia Rain Terminal Market, but that really did help two things, helping them keep their appointments and help them coming to group classes. Now, that's a market that you would have a hard time buying anything other than fruits and, fresh fruits and vegetables. But you could. I mean, I guess you could pick something else out there, but we're hoping that that's what they're using those for. And we also found that you can't help someone get better if they don't come in for care. So just getting them in so we had a chance to work with them, well, that was very helpful. For decision support, we looked at treatment decisions that had to be based on explicit, proven guidelines. And the healthcare organizations really needed to creatively integrate explicit, proven guidelines into day-to-day practice. So what we did is we took, for NCQA, you need to have 3 diagnoses that you at least have standardized guidelines for. And so we used diabetes, hypertension, and hyperlipidemia. And I just shared with you what the standardized orders were used for. Hypertension was from the 7th report of the Joint National Committee on Prevention, Detection, and Evaluation and Treatment of High Blood Pressure. And then the standards of care in diabetes were based on the American Diabetes Association standards. And these are the most recent ones that remain. For clinical information system, a registry was required for us to report in, and a registry is also a requirement in order to do population reporting for NCQA. And it really is a necessity when managing chronic illness, and by being forced to keep the registry and report on a monthly basis to the Chronic Care Initiative, it was a good way of sharing with everyone in the practice, and also setting some competition up between our centers and also between clinicians within the center. Refinement of the EMR was a major point in order for us to make sure that the clinicians were reporting the outcomes in the appropriate place so we could get that data out for reporting. And that remains an issue as we've switched our EMRs. The outcomes from the PA Chronic Care Initiative proved very, very positive. And I just shared some of those there for you, that the diabetics were really 33% more likely to have control of their blood sugar, 40% more likely to have control of their cholesterol levels, and 25% more likely to have normal blood pressures when compared to non-participating diabetes. Pennsylvania has now broadened this to 151 practices across the state, and they just received a Medicare demonstration project that wasn't involved in the original initiative. And most importantly, this program survived a change in administration from a very, I'd say, liberal and supportive administration to Ed Rendell as a Democrat to a very conservative Republican administration, and it's because the payers themselves are providing the funds for the program. I say you can do it because with help of our IT person, we did 4 at the same time. You do need a committed staff who like detail work. And you need to have both a clinician and an IT person that will work on this together to be successful. You do need to purchase an NCQA survey. And then when you look at the survey initially, allowing at least 6 months out, then you need to compare the requirements in the survey to the status within your health center. So you have to be honest with yourself. And then you need to create new policies, procedures, and documents and documentation. I really recommend attending an NCQA workshop, one of the regional ones, to learn how best to demonstrate that you've met the standards. Because when you do the survey, you not only have to have the policy, but you have to have the screenshots other material to upload that says that you truly met that requirement. We needed to set time aside for the clinical and the IT staff to devote to the program, and so we planned a calendar out ahead of time that also forced us each to do our assigned tasks before we met. And so we divided the work that came together and then to critique each other. And then we also have to upload everything into the survey. And then the final thing you need to do, you've got to meet the contract expectations. They don't really review you until they have your payment in hand. And we'll talk a little bit about that more as we move forward. Other changes that were required was an EMR and an electronic prescribing were not required, but they were very helpful for us. And they probably are what enabled us to be admitted into the Chronic Care Initiative also. With the 2011 NCQA Standards and Meaningful Use funding, it's going to be even more important today that people have EMRs to help them with this process. You need a patient registry and performance reporting that's required, and we'll talk about that more as we look at the standards. And then you need to do a lot of practice re-engineering. One of the areas we had to really improve on was tracking of referrals and tests that were ordered, and how we get that information back into the clinician so the clinician could act on that. As again I mentioned earlier, we did hire RN care managers to help with the self-management and also to follow patients who were at high risk for admissions to the emergency room or hospital. The long-term pay-for-performance programs are only going to remain if indeed by paying for better primary care, they're paying for less admissions to the ER and the hospital. Now, we opted not to do advanced electronic communication to date because of the population that PHM serves. Our chronically homeless do not necessarily have access to computers, and neither do our public housing, where they may have some community access. It's not to the level that we kind of thought we would be saying we did something that really wasn't going to be possible. But I think as we move forward that there's going to be more and more, and I understand meaningful use is going to require some of this too. Benefits of NCQA recognition is they really improved healthcare value, higher quality, lower cost, preventing the need for hospital and ER admissions, quality gains and cost savings through adoption of medical homes. And I'm giving some references here that you can look at in terms of understanding why there's a benefit to it. Improve satisfaction, which I mentioned as we began with both the patients and the clinicians. And then multiple patient-centered medical home findings are on this particular website that I've given to you. Additional benefits is NCQA program it's the most widely used to date. There's certainly there are other groups that are now competing for patient-centered medical home recognition. It's a practical plan for a practice transformation and definition of what's best in primary care. It's evidence-based and it's built on solid research. It's a collaborative process that improves team-based care. It's flexible and applicable to a wide spectrum of practices, basic to complex and small to large. It addresses and solves the problem with a common solution for payers and practices. And in Pennsylvania, it was selected because this was the recognition that the payers said they would acknowledge in order to provide funds for a pay-for-performance program. The new NCQA standards that have gone into effect, and if anyone has not put an application under the old, you have to go in under the new standards. And they are a little bit higher than the standards that were there primarily. But they still have the 6 areas of enhancing access and continuity, identify and manage patient population, plan and manage care, provide self-care and community support, track and coordinate care, and measure and improve performance. Each one of those 6 components has a must-pass element, and we'll be looking at those later in this presentation. Meaningful use in medical homes. The updated medical home guidelines align for meaningful use standards for electronic medical records. I think meaningful use is going to be difficult to meet without having technical assistance for programs. And I just want to mention that there is assistance available using regional extension centers that are funded by the Health Resources and Services Administration. In Pennsylvania, we have PA REACH, which is one of it. There are those programs around the country. Changes made to NCQA standards for 2011 is the alignment with meaningful use. They have a stronger focus on integrating behavioral health into primary care. They add an optional standardized patient experience survey, which I have some problems with. It's very long, and they want the clinic to get an outside group to do the survey and it not to happen on the clinic site, which I think is very difficult with the homeless population. And it also is a very high reading level. But I believe they are working within NCQA to deal with that. At this point in time, you can use theirs, but you can also use your own. And we use the medical outcomes satisfaction survey and have had for a number of years. Greater involvement for patients and families in quality of care improvement is another focus of the new standards. And there are now pediatric examples and explanations when they were not within the original standards. What's next for Mary Howard? Mary Howard will reapply for recognition in May of 2012 under these new guidelines. We intended to do this earlier. We transitioned to a new EMR. It did not go smoothly. We went from MISIS to Allscripts. And in order to reapply, that we really need 3 months of good data. The reapplication has to occur no later than 3 years after our most recent. So our most recent was May of 2009. And we were accepted to receive recognition survey services for our next NCQA review under the HRSA's Patient Centered Medical Home Initiative, which will be a lot of economic help to us. And we also had applied and we got some help in terms of moving ahead in terms of medical home and asked for funds to have dedicated IT services. So we are now customizing the EMR, and we're also doing more training of our staff so that we will have good data. Standard 1, I said I would talk more, and Standard 1 is worth 20 points. The points are broken down in terms of, and so you know where you're going to get more points, and so where you put the emphasis. Access during office hours is the must-pass element in this particular standard, and a little bit later on I kind of break down so you see what's required in terms of that. But it's looking at this standard, enhanced access and continuity, so it's access during office hours, after hours access, electronic access, continuity with the provider, medical home responsibilities, cultural linguistic appropriate services, the practice team, and then we'll go on to Standard 2, where it's worth 16 points. And a must-pass element in here is use data for population management. So that's why I'm saying a registry is required so that you can do the population management. And there's also points for clinical data and comprehensive health assessment and using the data for, as I said, mentioned before, for population management. Under Standard 3, plan and manage care, 17 points. The must-pass element here is care management. That's why I'm saying that where the Wagner model really helps focus on this and would be a good resource to look for as you develop care management within your programs. It also looks at implementing evidence-based guidelines to identify high-risk patients, medication management, and use of electronic prescribing. And that was an area when we first went in that we were just beginning to use, but now we are doing almost 100% electronic prescribing. Standard 4, support self-care process, is the one again who has, so that really relates to the self-management again, and then to community resources and providing referrals out to community resources. Standard 5, referral tracking and follow-up, again, is the must-pass element. That was an area, and you've got to pass these must-pass elements in order to be recognized at any level now. And then test tracking and follow-up. And coordinate with facilities and care transition. One of our goals under the Chronic Care Initiative is to contact patients within 24 to 48 hours of discharge from the ER or the hospital in order to do medication reconciliation, because we know that that's a point when patients frequently get into difficulty. Standard 6, 20 points, measuring performance. I should say the must-pass is implement a continuous quality improvement plan. Then measuring performance, measuring patient-family feedback. These are these satisfaction forms we're talking about. Demonstrate the continuous quality improvement. Reporting performance and reporting data externally. So you're not just reporting within the clinic or within, for us, within the clinic or in PHMC, but we report out, as all FQHCs do, UDS, and we also report out to family planning, and we're reporting out monthly to the Chronic Care Initiative. Scoring for NCQA. Level 1, you have to get between 35 to 59 points. And you must pass 6 of the 6 must-pass elements. And if you look at the bottom of this slide, a must-pass element has to be passed at 50% or greater. And we'll look at that when we look a little bit at, as I said, at the first standard, an example of that. To get level 2, you have to get 60 to 84 points. To get level 3, 85 to 100 points. And truthfully, and you know what, this is an error because you have to pass 6 of the 6 must pass. So that's an error on this slide. I want to point that out. You have to have 6 of 6 must pass for all of the levels, and particularly for level 3, which is the highest. There are, most practices are at level 1 or level 3. Most times if you can get to level 2, you really can bump up to level 3. I'm going back now to the standard 1, access during office hours, that must pass element. And this is what, when you get the survey, it tells you that your practice has written process standards and demonstrate that it monitors performance against those standards. So if you have a written process, and in the written process, you say that you allow for walk-ins, and in some cases people only have walk-in appointments, and that's what your policy says, then you've got to show some type of printout. For us, it will come from the EMR that really labels what those, and so it will show how many people that came in for appointments, how many canceled appointments, and how many people will walk in and have same-day access. So it's not just having the policy, but it's able to show. And you need to provide same-day appointments as a critical factor on there. You have to also timely advised by telephone. And for this, before, we did telephone logs in terms of the time that a call was in and the time that a practitioner called, and did it meet the standards that they had in our policy. And of course, we differentiated in that whether it was someone who's calling in for renewal of a prescription versus someone who was calling in because they had some concerns that they wanted to talk to the clinician about. And then another piece of this is that you document critical advice, and then you would have to, again, show all de-identified data, but you'd have to show where there was some advice given in the record, and that telephone call was documented, and the advice can be seen, and that can be uploaded into the survey. If you'll see here, this has 4 factors under this particular 1A, and you can get 100% with 4 factors. You get 75% with 3, and you get 50% if you have 2 or more. So if you only met one of these factors, you wouldn't have passed the must-pass element, and you wouldn't be able to be recognized at any level for NCQA. The process. The process is to obtain the patient-centered medical home standards and guidelines online. And if you go on to the NCQA website, which is listed below on this slide under training, you can pick up the recognition program, and you'll be able to download the standards and the guidelines online. And they will provide one of these with no cost for each site. You then later, you need to purchase an interactive survey system, and for that, there's one ISS, or Interactive Survey System license, for each site, and there is an $80 charge for that. There is a training that's available on the website, and there are free online and monthly trainings. In other words, there is some free training that's online at all times. You just have to go in and check, click on, and you can look at that at any time of the day or night. And then they have monthly trainings that you can go on. In addition, they have regional classroom trainings, and they are expensive. They're $850 to $995, but I recommend them highly because they really show you how to demonstrate how you met the policies or the requirements. And there isn't just one way to do it. And I found that invaluable when I didn't necessarily do what they showed me, but it gave me ways that we could demonstrate that we met whatever that standard was. Continuing, you complete the online application, and this requires that you're uploading into the survey, and you're either, in some instances, you're typing in some instances, you're uploading surveys and screenshots. And I would never have been able to do that without the IT person sitting next to me. And then at the point you're ready to submit, you have to have NCQA enable your ISS tool. You've purchased it, but they have to enable it before your survey then can be completed and go through. And then there is a fee that they will accept by check or credit card, and it's based on the number of providers, and it's about $400 to $500 per clinician. And the $400 is if you're part of a program that, like the Pennsylvania Chronic Care Initiative was part of a program. They knew they were going to have a lot of these clinics coming through, and so they gave them a reduced rate of $400. There is another decision to be made. You can go as a single site, or you can go as a multiple site. When we were initially applying in May of 2009, the multi-site application wasn't working well. We opted to go with a single site. I believe we'll opt to go with single sites again, and one of the reasons is you wouldn't want one site to possibly pull down all of your sites. I think most times If one site is doing well and you're doing similar things across a network, that wouldn't be an issue. But just in case, I think our decision is going to be the safer thing to go through individually. One of our sites is going to be a site that's never gone through before, the care clinic. So in particular, that's another reason we don't want to go as a network. If you opt to go as a multiple site, it would be if you have 3 or more practices in a network. They need to use the same EMR, and the same person has to be willing to sign the agreements for all of those sites with NCQA. I just recommend that you take the challenge, that all indications are, and we believe this, that if you receive the recognition, it really is not just quality care for patients, but quality work environments for providers. And I can say with the Chronic Care Initiative in Pennsylvania, all of the practices, there were several MD practices that said this was the first time that they were really enjoying practicing primary care. And a lot of this was taking the responsibility off them and having the team-based care and using RN care managers to get really great outcomes, and then to be able to see those outcomes and feel good about them. At this point, I'm going to turn it back to Anna, I believe.
Thank you so much, Nancy, for your wonderful slides and your explanation of the NCQA Patient-Centered Medical Home Standards and how Mary Howard walked through those standards. HRSA will cover the cost of the survey tool. If you apply through the HRSA website on their patient-centered medical home initiatives, you just need to apply, and they will cover all of the fees for the survey tools because they really do want to encourage any of the grantees to pursue recognition. So I just wanted to clarify that because I know on top of some of the other costs incurred with this process that it's nice to be able to waive that fee. I also wanted to add that the council has created multiple resources to help you with the patient-centered medical home journey. And the patient-centered medical home resource catalog is a list of tools and websites and particularly newsletters that I highly encourage that you sign up for so that you'll get a continuous update in your inbox about ongoing patient-centered medical home demonstration projects, initiatives, and also best practice examples. There's a really wonderful newsletter out of I believe it's the Safety Net Medical Home Initiative, as well as the Primary Care Patient-Centered Medical Home Collaborative. Part 2 of the resource catalog will list and describe in detail different patient-centered medical home practice assessment tools to assist you in engaging your organization's readiness to implement patient-centered medical home. And many of these tools are really geared towards safety net practices. So I would encourage you to look at some of these tools and use those as you begin to assess your practice and your readiness to begin this process. And the third section lists the various credentialing, accrediting, and recognizing organizations for patient-centered medical home. And then lastly, I would just like to announce that the Council will offer a pre-conference institute Tuesday, May 15th at the National Conference in Kansas City, focused on patient-centered medical home and meaningful use of health information technology. And this conference will really focus in more detail on the issues that Nancy covered in terms of the 6 standards of NCQA, patient-centered medical home recognition, and really focus on the potential challenges and successful implementation with special population and some of our particular challenges in working with the homeless population. So with that, I am going to pass this back over to Melissa, and she will facilitate question and answer.
Thank you so much, Anna. Thank you, Nancy Rothman, for that terrific presentation. We have several questions from three of our participants, and I think maybe I will start with you, Anna, because I can see these most clearly. The first couple of questions from Louise are about advantages of the NCQA versus Joint Commission accreditation process. Are there advantages is there any advantage of using NCQA over Joint Commission if you're already a Joint Commission accredited for ambulatory care? Anna, can you address that question?
Yes, I can. I would refer you to HRSA's Patient-Centered Medical Home Initiative section of their website, because they have a comparison chart, the National Quality Recognition Resources Comparison Chart. And so they compare the three most current recognition and crediting organizations, and that would be NCQA, the Joint Commission, and then the Accreditation Association for Ambulatory Health Care. In general, however, it really behooves you to look at what's going on in your state and region, because there's many state-related initiatives that will help you make that decision. So, for example, in Pennsylvania, because we had the chronic care initiative, that would really involved NCQA, and so that was the organization that was being promoted and supported, and therefore anyone who was engaged in that process was going to pursue NCQA recognition. NCQA has really concentrated on issues like access to care, patient-centeredness, care coordination, as well as population health management. So it's very useful in evaluating your processes for things like appointment making, triage, follow-up, self-management support. It really does, as Nancy demonstrated, really follows the Wagner chronic care model. The other thing with the most updated 2011 standards of NCQA, it is very closely aligned with the meaningful use requirements for implementation of EHR and being eligible for the incentive funding with implementation of your electronic health record. So that being said, in the medical home world, it really has a little bit more visibility with third-party payers. When we think of the Joint Commission, historically, it's been excellent evaluating fundamentals of clinical accuracy and quality of things like lab testing, infection control, patient safety, clinical competence, and performance improvement. So there are some benefits there, but again, I would strongly encourage you to look at what is going on in your own state by contacting your primary care association and really aligning yourself with what's going on with any payment incentives in your own state.
Thank you, Anna, for that thorough response. The next question will go to Nancy. And Nancy, we have a question we have a couple of questions from Philip. The first is, how are labs and lab results recorded and then communicated at your site? Are you using EMR, EHR, or manually by hand? I assume that's like paper chart. And then his second question is related to how you approach complex or multimorbidities, chronic conditions. So how do you systematically approach your requirements for chronic conditions as you approach patient-centered medical home documentation? Nancy?
Okay, remind me as I go, but the first one was asking how we handle lab testing, right? And referrals, I think it was in there too. I mean, we are using an electronic medical record. And so when a clinician orders the lab, it goes into the EMR or makes a referral to a specialist. Then and what we do is we make that appointment for them. We do whatever paperwork is required for their payer to pay for that specialist or for that test if it's going outside to get that. We then try, and it's harder with our homeless than it is with public housing even, but to remind the people of the appointment before the appointment. We then call the day of the appointment to see whether the patient went or not. If they didn't, we try to get this process started all over again. If they did go, we remind either the testing facility or the referral facility that we need to get the report back. When that report back comes, and we may have to call a couple times in some instances to remind them, we then scan that into the EMR. It's hooked back up to the order, and then it's flagged for the clinician so that the clinician can see very shortly after a report was what was in that report. So that's how we do referrals and testing. And we really have worked to refine that and felt we really needed all of those steps. We also provide tokens or cab fare if that's a necessity for our patients. In terms of the complex patients with, and people have, the metabolic syndrome, and that's why we picked diabetes, hypertension, and hyperlipidemia. And because in Pennsylvania, we are required to have collaborating physicians, and our collaborating physicians meet with the nurse practitioners monthly. But if we were a physician practice, I would imagine the physician practice would meet monthly. And one of the things we do then is that we look for, we wanted to have standardized orders for diabetes, for hypertension, for hyperlipidemia. And so with the communication with the nurse practitioners and the physicians, we sought out the best resources, the most recent that were there. We all read that material. We came together with a procedure that we had agreement on between the nurse practitioner clinicians and the physicians, and then we've standardized that. It doesn't mean that someone may not have to, that's what they should be doing most of the time. There are always times that maybe something that isn't working as normal, or they have another problem that interferes with that, and then they deal with that. So we aren't tying clinicians' hands, but we are helping by having standardized orders, which really helps when the patients come in, that they then, we know what lab work needs to be done when they come in. We know that the diabetics need a leaf exam once a year. So we know what we want to, we want to document self-management goals. So all of that are in these standardized orders and protocols. I hope that helps.
Thank you, Nancy. The next question for Anna from Louise is, I believe she's asking about the NCQA application fee. So for purposes of the NCQA application fee, how is clinician defined? Anna?
And Nancy, you can jump in and correct me. I believe it is physician, nurse practitioner, or I believe that physician assistant, if they are their assigned PCP, is included. And when I say physician, that would be MD and DO. I'm not certain, and I would certainly need to check on this, whether certified nurse midwife is included. Nancy, I'm not sure if you know that or not, so I will pass it over to you.
I do not know about certified nurse midwife, but I would expect that it would be, but I don't know that for sure. But otherwise, you're correct. It would be the MD-DO, CRNP, or PA. The primary care clinician is who they're looking for.
Thank you, Anna and Nancy. The next question, I believe, is going to Nancy. Louise asks, can you describe the type and amount of staff resources, time, and cost required for pursuing NCQA recognition? Nancy.
How can I say? I think one of the major costs or resources, but again, because of the pay for performance under the PA Chronic Care Initiative, Elaine and I were able to justify to the organization the RN care manager. I mean, that's essential. So when you're talking whatever the cost of a salary and benefits are for RN care managers. And I mean, we have relatively small practices. If you had larger practices, you would need more RN care managers. But in order to kind of help with the cost, we really work with the clinician. In our case, the certified registered nurse practitioner and the RN care manager that are working as a team. And you do have to build the trust between the two of them so they aren't duplicating information and are able to hand off patients between the team. And therefore, where we do have the cost of the RN coming in some instances, as they've developed, we're taking less of the clinician's time. And I think that's what came out of the Chronic Care Initiative in Pennsylvania, is that the clinicians weren't feeling they had to do all of it themselves. There is time. I mean, I took a lot of my time. I'm a consultant, and I'm 50%. I'm a faculty member, but I'm 50% with PHMC, and it took a fair amount of my time. It took an IT person's time to do it. So there are resources, and then, I mean, we're using the $5 gift cards. You know, it's certainly, if you get somebody in for treatment, it's worth the $5 for the other payment that comes in along with it. So I hope that helps.
Thank you, Nancy Rothman. Thank you, Anna Gard. Thank you, participants, for joining us.